Creating a permanent access for dialysis requires physically wiring a high-pressure artery directly into a low-pressure vein. Because of this connection, the native venous system is suddenly forced to bear the brunt of the forceful, pulsatile arterial flow. The human body does not tolerate this hemodynamic environment. In response to the shear stress, the vein's inner lining develops neo-intimal hyperplasia. Neo-intimal hyperplasia is the rapid, abnormal growth of cells in the innermost layer of the blood vessel. This tissue thickens inward, creating an ever-worsening stricture, or stenosis, that chokes off the blood supply. Because of this aggressive hyperplastic response, every arteriovenous fistula and synthetic graft is living on borrowed time. If left completely untreated, the vessel will inevitably thrombose, clotting off entirely and dying. This is a graft tracking flow rates over time. Clinicians intervene when the access develops slow flows. The standard diagnostic threshold to trigger a salvage procedure, a fistulogram, is a flow rate dropping below 600 cubic centimeters per minute for a synthetic graft, or 500 cubic centimeters per minute for a native fistula. Since anatomical failure is a biological certainty, maintaining a patient's lifeline requires mapping these degrading flow dynamics and executing a mechanical intervention before the vessel fully occludes. Surgeons typically rely on one of two permanent access architectures. The first is an arteriovenous fistula, a direct subcutaneous connection between a native artery and a native vein. The second is an arteriovenous graft, which uses a synthetic tube to bridge the distance between the two vessels. The native fistula is highly durable, but it requires 3 to 4 months to mature, meaning the vein needs that time to dilate enough to handle dialysis needles. The synthetic graft, by contrast, is fully ready for use in roughly 14 days. Each structure has a predictable failure point. Synthetic grafts almost universally develop intimal hyperplasia at or immediately downstream from the venous anastomosis. Fistulas present more variability, but they typically fail at the juxta-anastomotic region, the segment of vein directly adjacent to the arterial connection. Before an interventional radiologist can attempt to salvage the flow, they have to know which of these two architectures they are dealing with. Identifying the hardware dictates exactly where the anatomical bottleneck is likely hiding. The diagnostic workup begins outside the patient's body with a strict physical exam. The first step is visual. If a patient presents with generalized swelling in the arm, breast, or chest wall collateral veins, the downstream venous pressure is backing up. This indicates a central venous stenosis deep in the chest. Conversely, looking at the hand can reveal dialysis-associated Steele syndrome. If the fingers are pale, cold, or discolored, the access is siphoning too much arterial blood away from the extremity, leaving the distal tissue ischemic. Next, clinicians use a stethoscope to evaluate the acoustics of the blood flow. A normal, unobstructed graft or fistula produces a low-pitched brew. A brew is the audible sound of turbulent blood flow rushing through the vessel. In a healthy access, this sound is continuous through both the systolic and diastolic phases of the heartbeat. This animated diagram shows how acoustic frequencies change based on vessel diameter. When flowing blood hits a narrowed choke point, the velocity increases sharply. This translates acoustically into a high-pitched brew, allowing the examiner to pinpoint a localized stenosis simply by listening. These visual and auditory markers act as a superficial radar. They allow the clinician to detect hidden internal turbulence and translate it into a clear target before making an incision. The final step of the algorithm relies on tactile feedback. A functional access should have an easily compressible pulse. When palpating the vessel, the clinician should feel a thrill, a palpable vibration caused by the turbulent flow, but this should only be present directly at the arterial anastomosis. If that thrill is only palpable during systole, or if the vibration can be felt migrating further downstream into the venous outflow, the underlying pressure gradient is abnormal. That downstream vibration is the physical signature of a stenosis. The character of the pulse maps the exact location of the stricture. A highly pulsatile, forceful water hammer pulse means the examiner's fingers are positioned pre-stenosis, where pressure is building up. A weak, diminished pulse indicates a position post-stenosis, where the flow has been choked off. In a classic failing straight forearm graft, these three variables align perfectly. You identify a forceful, bounding pulse, hear a high-pitched bruit, and feel a strong, continuous thrill at the site of blockage. By systematically combining what they look at, listen to, and feel, the clinician constructs a precise hemodynamic map. This physical assessment dictates exactly where the intervention radiologist will direct their wires once the patient is on the operating table. Once inside the interventional suite, there are strict clinical rules of engagement. There is only one absolute contraindication for attempting an endovascular salvage: active infection. Manipulating an infected fistula or graft carries a massive risk of seeding bacteria into the bloodstream and inducing endocarditis. A fresh access, one created less than 30 days prior, serves as a relative contraindication. Early stenosis almost always points to a technical error during the initial surgery, and attempting to forcibly dilate a newly healing anastomosis creates a severe risk of vessel rupture. For venous obstructions, the operator uses antegrade access, advancing the catheter in the blood flow's direction. To see arterial inflow, they temporarily block venous outflow, forcing contrast dye to reflux backward against the current, mapping the arterial anastomosis. Navigating these vessels safely requires strict adherence to anatomical flow directions. The operator must verify the layout and ensure the patient's physiology can withstand the mechanical stress of the procedure. The salvage protocol begins with pharmacological preparation. The patient receives 3,000 to 5,000 units of heparin to prevent clotting around the wires. The operator may also inject a vasodilator, like nitroglycerin. If the vessel narrows due to a temporary muscular spasm, the vasodilator will resolve it. If the narrowing remains, it is a true structural stenosis. With the stenosis confirmed, the operator exchanges their initial catheter for a larger 5 or 6 French sheath. They advance a 6 to 8 millimeter angioplasty balloon directly across the stricture and execute multiple prolonged inflations to fracture the hyperplastic tissue. A critical safety protocol dictates that this balloon must never be completely removed from the guide wire during subsequent diagnostic imaging. If the high-pressure inflation causes the vessel wall to tear, the balloon must be instantly advanced back into position and reinflated to tampen out the bleeding. Angioplasty in a dialysis access is not a gentle stretching of tissue. It is a violent, highly controlled mechanical fracture of the vessel's inner lining, explicitly designed to blast open the lumen and restore life-saving flow. A successful intervention requires meeting 2 strict criteria. First, the patient's physical symptoms, such as arm swelling or hand ischemia, must immediately improve. Second, the follow-up imaging must demonstrate less than 30% residual stenosis at the treatment site. Mechanical dilation has its limits. If the vessel exhibits severe elastic recoil, springing right back closed, or if the stenosis recurs within 3 months, a metallic stent may be deployed to hold the lumen open. However, continuous lesions longer than 7 centimeters or true structural aneurysms typically fail endovascular treatment and require surgical revision. Even with a flawless mechanical result, the biological reality of the access remains unbroken. The shear stress of the arterial flow persists, and the hyperplastic tissue returns. Roughly 75% of these treated stenoses will recur within just 6 months. Because these access points have such short lifespans, medical staff must adhere to a strict mandate for any patient approaching end-stage renal disease. Never place a PICC line in a chronic kidney disease stage 4 or 5 patient. A PICC line is a peripherally inserted central catheter used for long-term intravenous medications or nutrition. Placing one risks scarring the native arm veins, permanently destroying potential sites for a future fistula. A patient's venous real estate is strictly finite. Since hemodynamic failure is a biological guarantee, obsessively protecting these veins from unnecessary trauma is the single most important factor in extending a dialysis patient's life.